Hello everyone. So today we are going to take a look at Kaposi Sarcoma, and I think this is our first session on the malignant skin condition. We shall have a session on all the malignant skin conditions, including melanoma, basal cell carcinoma, mycosis fungoides, cutaneous T-cell lymphoma, and the rest. So it is very paramount for you to know these skin malignancies and how they look like, and actually how to make a diagnosis. So when you look at the picture that I've displayed, you see that someone has lesions which are a little bit nodular and getting from the skin that is on the leg. Someone has similar lesions on the covering the gingiva, lesions covering the eye or the sclera, and then also the leg. And then you also have these verrucous lesions also covering the leg. So KS or Kaposi sarcoma can present in different ways on different skins. So it is your role as a practitioner to know how it looks like and actually when do you suspect it and the different types. So Kaposi sarcoma was first described in 1872 by Maurice Kaposi, who actually described this condition among his 5 men, who he noticed that they had this similar clinical picture, having focal skin sarcomas. And according to him, by that time, he named them idiopathic mouth-pigmented sarcoma of the skin. So it is later on that we actually named them Kaposi sarcoma because of just in memory of his work and being the first person to describe this skin neoplasm. And then this became to be known as Kaposi sarcoma. Historically, also seen as chronic protracted condition in elderly men, particularly in the Jewish population, and also those individuals living in the Mediterranean or in Eastern Europe, having Eastern Europe descent. So it's a little bit rare, but it's also occurred in patients who had organ transplant, and they also had, and we also had an endemic form that occurred in Africa, and this gave rise to different categories that we have for Kaposi sarcoma. And when you look at patients living with HIV, they also had to get their own type that we call HIV associated. And this became a little bit of an epidemic when we had HIV or AIDS becoming an epidemic, especially in Africa. So we also got an HIV associated Kaposi sarcoma, which we call the epidemic type. And it has been associated with the human herpesvirus number 8, which was identified to be the cause of all the different variants of Kaposi sarcoma. And it is because of this virus that now people have started now to explain the oncogenic pathway involved in the different oncogenic viruses inducing cancers. For example, the EBV Epstein-Barr virus that is implicated in Burkitt lymphoma, other forms of the non-Hodgkin lymphoma, the other virus like the human papillomavirus that is implicated in cervical cancer, Bowen's disease, and the rest. So you'll find that so many viruses have now been shown to cause malignancies on the skin. So we have in the pathogenesis, usually in the natural history, we have the virus affecting the endothelial cells. So, and KS is usually an endothelial cancer in origin, and particularly it loves the vasculature. So, vasculature, lymphatics, wherever you have these endothelial cells, you can have the Kaposi sarcoma arising from there. It can also affect the spindle cells. In this case, you have spindle-shaped cells expressing the endothelial cell markers, especially the CD31, as well as markers for the blood, especially the CD34, and also lymphatic differentiation, which is the VEG2, that is the superendothelial growth factor receptor 3, as well as the podoplanine. So we find that the HHV8 infection, the human herpesvirus 8 infection, infects both the blood and then the lymphatic endothelial cells, causing the transcriptional reprogramming and then also mixed endothelial characteristics that you see in the KS. So the virus itself has trophism, or it has lab, or it favors the endothelial cells with both from the lymphatic origin as well as the circulation origin or the blood vessel origin, both the arteries and then the veins. So you find that upon infection of these cells, the virus will reprogram the cells, making them immortal, making them get these neoplastic transformations that ends up giving the Kaposi sarcoma. So there's still a debate case whether it is a hyperplastic or neoplastic process. Up to now, it is not well categorized whether it is a benign tumor, which is just a hyperplasia, or is it a neoplastic transformation. So it's not yet clear where it falls. And then the role of human herpesvirus 8 is usually to stimulate cell proliferation and angiogenesis, and it also inhibits apoptosis, meaning that upon infection, these cells attain immortality, so they cannot die, and that's why they end up proliferating, causing more of the problem. And this is what the virus does. So in the immune response, usually, progression can be exacerbated by either inflammation and also immune constitution, especially in HIV patients. When we start treatment, oftentimes you find that maybe someone has a very good skin, but once you start treatment, because of the iris, which we call the immune constitution syndrome, the malignancy can actually be exacerbated. But later on, as the patient persists in their medicine, the immune system stabilizes, and then you can even get spontaneous resolution of these KS lesions. So when you look at the classification, as I told you earlier, KS is classified into four major groups. The first one is what we call the class Kaposi Sarcoma, and this is usually the one seen in the Jewish people or people with Asian descent. Those are the Mediterranean people, and then Eastern Europe type. Then you have what we call the endemic type, occurring commonly in children, that is common in the African belt. Then we have the HIV-associated Kaposi sarcoma, which we call also the epidemic type. Then we have the last one we call iatrogenic Kaposi sarcoma, the one that usually occurs in immunosuppressed patients like transplant patients or patients on chemotherapy. So those are the four major types. So starting with the first one, the class type, predominantly, as I had mentioned, we usually see it in the Jewish people or population, and it has a male predominancy, whereby we see a ratio of about 15 to 1, depending on the literature. But currently, the old literature puts it at 15 to 1. But currently, when you do the current data, you see that the ratio is between 3 to 1 versus 1 to 1. Then 2/3 of the patients usually develop the disease after the age of 50 years. So it usually has late more or less of a late onset. In the presentation, these patients usually get slowly growing pink reddish violet macules on the distal lower extremities, and they can progress to give you very thick plaques or even papulonodules, as well as polypoid tumors that can be easily bleeding on contact. Remember, this is a vesicular tumor, and initially the distribution can be unilateral, but with progression, it can become multifocal and also disseminated. And oftentimes, lesions can regress on their own or evolve into different stages, either from the patch stage to the from the patch to the plaque stage to the tumor stage or nodular KS. Then, oftentimes, lesions can be asymptomatic, but they can also occur in other sites like the mouth, the gastrointestinal tract, the GI tract. So you have to be very careful every time you are examining a patient with Kaposi sarcoma. Then you go to the next variant. This one we call it the African Kaposi sarcoma or the endemic type. So this type is not the one associated with HIV. You have to know the difference. So the endemic type is the one that was actually there even before HIV. And this was endemic and commonly seen in the Black Africans. And we usually see it with still slightly more of it favoring the males, and it could account to even up to 9% of all the reported cancers in the equatorial Africa. So meaning that it was a little bit actually more common even before the HIV came in. And it's also called lymphoadenopathic variant that primarily affects children, and it also has a male to female ratio of approximately 1:1. So it can also have variants. In some cases, it can have a nodular picture that can resemble the classic KS, or sometimes it can have an infiltrative picture, which is a little bit more aggressive and resistant to treatment. You can also have the lymphoadenopathic type that usually loves the lymph nodes, and this usually affects the children, and commonly, yeah, this one is the bad type, and it is fatal in most of the cases. So you have to know the difference between the classic type, commonly seen in the European countries, the Jewish people. Then you have the endemic type that is African, seen in the equatorial Africa, commonly also having variants. Either it can be nodular, it can be infiltrative, or lymphoadenopathic. The one we see in children, it is usually very, very fatal. As you can see here, this is the nodular type in that picture. So we can also have the iatrogenic Kaposi Sarcoma, and this is the one that is usually induced by the drugs that we give patients. So you may be treating maybe your psoriasis, you're giving cyclosporin, or maybe the patient has had a renal transplant and then they are on sirolimus as a chronic immune suppressant, or even corticosteroids. Then because of this immune suppression, they end up actually getting malignant transformation, giving you Kaposi Sarcoma. So that is the iatrogenic type. So we only see it in people with immune suppression. So we find that it is estimated to be common in post-transplant patients, with the prevalence ranging between 1% to about 4%. That is either in the Western countries to the Near East, that is the approximated prevalences. And men are more slightly affected compared to women, just like the other types of or variants of Kaposi sarcoma. So that is the cancer we're talking about today. So the appearance, it is actually similar to what you see in the classic KS, and it may resolve actually completely upon discontinuation of the immunosuppressive therapy. And in its behavior, it can usually, if you are giving maybe high dose immunosuppressive drugs, you can get it being very severe, resulting into even death with the internal organ involvement. So this is one of also the forms that is aggressive. The other form that is very aggressive is the one that we will see in children, the lymphoadenopathic type of the endemic type of KS that we see in Africa. Then the last type, or the last variant, is the AIDS-associated or related epidemic KS. So now this type of Kaposi sarcoma was actually now noted in people living with HIV. So that's why it comes with the word epidemic. We had an HIV epidemic that came along with this Kaposi sarcoma as one of the AIDS-defining malignancy. So it is one of the cancers that you can see in a patient and then say that maybe this patient is living with HIV. So primarily it occurs in it could occur in men who were having sex with men, and usually this particular group was also associated with having a higher prevalence of HIV compared to the rest of the population. And they were also having this malignancy as one of the AIDS-defining cancer. So to a lesser degree, it was also seen in female partners of affected men and women of certain regions in Africa and the Caribbean who became HIV positive via heterosexual contact. So up to 40% of men having sex with men and also having HIV were having this Kaposi sarcoma, compared to 5% in the other risk groups. Like now, those are the patients who were heterosexuals, and then 4% in children who were having HIV. So it can usually also fare in settings of immune reconstitution syndrome, where you are starting your HIV treatment, and then because of the immune system waking up, then you can have a flare of Kaposi sarcoma. So it can also occur in patients who are actually on routine antiretroviral therapy, either they are on TLD, that is tenofovir, lamivudine, and bemnifosbuvir combination, or any combination, they can actually get KS attacking them. So as you've seen, it is commonly in patients living with HIV, also associated with advanced immune impairment. That is the advanced HIV, and that is when your CD4 count drops below maybe 50. So the lower your CD4 count is, the higher the risk of developing this debilitating skin neoplasm or vascular neoplasm. So lesions can usually vary. So someone can have erythematous macules, papules, plaques, as well as purple-black tumors with hyperpigmentation, and this is due to because of the hemostatin. And the distribution, commonly we see these lesions on the trunk, the midface, particularly the nose, and then the hard palate, as in the picture that I showed you. And this usually comes with a cosmetic disfigurement and concerns. So internal organs can also be involved. More commonly, the KS can involve the GI system, the lymph nodes, the lungs, and every time you have it disseminated, it usually carries a very, very bad prognosis. So when you look at other things that can come with it, we have lymphedema, and in this case, you can get constricting plaques, which can impair blood supply to the lower limbs, eventually causing ischemia, and then eventually you have dysfunction or even loss of the functionality of the lower limbs. And can also cause chronic lymphedema. Then someone can present with elephantiasis nostrus, as you see in other cases of chronic lymphedema. So in this picture, I'm trying to show you the different ways how Kaposi sarcoma can present. You see that in this picture, we see it infiltrating the eye. This is a tumor infiltrating the eye. We see this on the trunk, that erythematous plaque, that was Kaposi sarcoma. We see it on the soft palate all the way to the hard palate. Then you see these nodules in the lower limb. You see it here on the upper limb. You see it here on the back as well as the face. So all these are the different manifestations of how it can look like on the skin. So when you take off a sample and you are doing your histology, this is the picture you've seen. So in KS, depending on the stage, whether it is a patch, plaque, or nodular stage, there's usually one processing factor, is the vascular involvement. Since you are having it is a vascular tumor, and then you have these spindle cells undergoing hyperplasia. There are very many spindle cells, and then you're forming very many blood vessels angulating at different levels. You will see a lot of very many blood vessels in the histological picture with thinned out, or what we call the slit openings. So the openings are very small. And then because these are new blood vessels that are forming, they're usually very leaky, so you have edema surrounding them. At the same time, red blood cells can extravasate from these blood vessels, so you get extravasated blood outside, and then usually when you destroy these blood vessels, you end up with hemostatin, which is the black pigmentation that we usually see. So those are the pictures that you see. So in summary, when you look at the patch stage, which is the first stage, you'll see superficial dermal proliferation of small angulated blood vessels, which can actually resemble lymphatics. And then you have sparse infiltration of lymphocyte plasma cells as well as spindle cells. So as you progress to the plaque stage, you will see vascular proliferation that extends a little bit deeper into the subcutis, and you have spindle cell populations, usually with these cells usually small and round, with branching blood vessels. Then in the nodular stage, you have replacement of even the dermal collagen with the spindle cells, and this can form now intersecting vesicles, and then you have your slit-like vasculature spaces containing the red blood cells, and then also creating a sieve-like pattern that you usually see in Kaposi sarcoma. So the challenge is when you are taking off a sample for KS, especially if it's involving the lower limb, this is one of the hardest histology to read. Oftentimes, they will give you unspecific findings. You may need to take off multiple samples from multiple sites so that you actually capture the typical picture in KS. So in advanced cases and atypical forms, you can get the lymphangioma-like KS, which in that case you'll get the prominent ectatic vascular networks. And in cases like the sarcomatous KS, which is a little bit rare. You get more aggressive forms with nuclear polymorphism with a lot of narcotic activity, and this is common seen in the African endemic type KS, especially the one we see in children, the endemic type, the one we see in children. So you can also use other diagnostic markers like the LANA1 antigen, which is against the human herpesvirus 8, and it is very sensitive and specific marker for KS because you know that this virus was identified. You can actually reach a conclusion that this is actually Kaposi sarcoma. So in this slide that you see here, so this is how the picture will look like if I imagine 5 and then we go through. So in this case, if you're looking at the inset here, you see all these are vesicular spaces that are looking like slits with a few trapped red blood cells. You see that those are red blood cells that appear in red, but then you see this entire picture. Then you see this infiltration with these spindle-shaped cells, as you can see here. If I imagine 5 now, this is an regular type. And then these are your spindle-shaped cells, all these they have now replaced the collagen, and you're just seeing red blood cells with so many spindle-shaped cells. So that's how the histology will look like. Then, when you go through the different differentials that you have to think about when you make diagnosis of KS, so if it is a patch stage, you have to distinguish it from other things that can look similar. For example, you have to distinguish it from other conditions of mycosis fungoides that can give you a patch stage. You can also have to distinguish it from capillary malformation, other vascular tumors, venous hypertension changes that usually see no extremities. That one you can understand it more if you look at the strict classification. And then what will save you is if you do the human herpesvirus 8 serology, and then it is what? Positive, then that will confirm for you that it is KS. If it is nodular, you may need to distinguish it from the Kaposiform hemangioendothelioma that can look like KS. You have to distinguish it from other things like bacillary angiomatosis, other things like pyogenic granuloma. So all the things can give you a similar picture, even as spindle cell hemangioma and the angiosarcoma. If it relates KS, you have to distinguish it from pseudo-Kaposi sarcoma. You have to distinguish it from Stewart Bluford syndrome and other mimickers like fibrosarcoma, leiomyosarcoma, and cutaneous metastasis from other solid tumors. So in this case, we need to do a lot of investigations to confirm and rule out all these other conditions. So when it comes to treatment of Kaposi sarcoma, the treatment goal is usually not to cure because causing cure is a little bit unrealistic and oftentimes not possible. Maybe in some lucky patients who get spontaneous resolution, for example, the ones who get the iatrogenic type of Kaposi sarcoma, when you take away the immunosuppressive drug, you see that the body ends up clearing actually all the tumor lesions by itself. But the rest, you may find that you are just improving cosmetic appearance and prevent progression of the tumor. And in these treatment modalities, you can opt for things like surgery in case you have a tumor that you want to remove, like a solitary mass, maybe it is on the gums, it is on the palate. You can do surgery and then you debulk the tumor. You can do other things like the cryotherapy, you can do laser, you can do photodynamic therapy, and then you can also do interventional chemotherapy where you give chemotherapeutic drugs like the vincristine and vinblastine to try and cut down these tumor cells. Then topical treatments like alitretinoin can also be used, though this is very expensive. And then imiquimod has also been used in some trials. And this, we know that imiquimod usually stimulates the production of tumor necrosis factor, which is very key in response to viral infections. So that will act in that way. So we can also do other things like radiotherapy. In this case, we can give a localized high dose single dose radiation. In this case, we'll give the gamma rays, the GY between 8 to 12, and then this is given as a single dose. And then you can also do total body electron beam therapy in case someone has generalized or even organ involvement. So in systemic treatments, you can give chemotherapy if the patient has extensive multifocal or even aggressive KS. And in this case, you can opt for the liposomal anthracyclines or things like the paclitaxel, gemcitabine, or even vinorelbine as the drugs of option. So you can also do targeted therapy. In this case, you can give the anti-angiogenesis agents like the Zubamab, and in this case, this is a biologic, still more expensive. We can also give other things like the immunomodulators like thalidomide, though it has a lot of side effects. You have to weigh the benefits versus the risks when you're giving this drug. Then there are also other investigative drugs like the interleukin 12 inhibitors, like tyrosine kinase inhibitors. They are still under investigation, and possibly when they're out, we shall see their role in management of Kaposi sarcoma. You can also give antiretroviral therapy in case someone has HIV. You can start the ART treatment, and when you start this treatment, oftentimes the CD count goes up, and then you end up clearing some of the lesions of KS, resulting into dramatic cosmetic improvement. So in special cases like the organ transplant patient, you may adjust the immune suppression, and in this case, you have other substitutes like the sirolimus being substituted for cyclosporin, and this usually minimizes the suppression, and then someone can get even resolution uh, um, from the KS that is iatrogenic. So that is our Kaposi sarcoma, and that is the discussion that we've had today. So just a reminder, we know that our Kaposi sarcoma was first described by the scientist before Kaposi in the early 1800s, and then he described 5 people with the condition. Then later on, it was given the name Kaposi sarcoma. Then we have 4 types, where we say that the first type, we call it the endemic type, the one we see in Africa. Then we have the epidemic type, the one associated with HIV. Then we have the iatrogenic type that comes after immune suppression, maybe after transplant. Then we have the last one, being the classical type that we see in the Jews and people in the European countries. So for KAS, remember that it is all the cases, all the variants have all been associated with infection with human herpesvirus number 8 as the major driver for this neoplastic transformation. Thank you very much. See you in the next video where we shall cover other malignant conditions that can affect the skin.